Welcome back to the Cert Prep Academy CNA Exam Prep Podcast, everyone.
It is great to be back with you all.
It really is. So just a quick reminder, this is an 11-episode series where we cover all 6 NNAAP written exam topics.
Right, and each episode completely stands alone.
Exactly. You can just jump around to whatever topic you need to study today. But today is Episode 4, Physical Care Part 4, Vital Signs and Measurements.
Which is a huge one.
Oh, absolutely massive. Our mission today is really doing a deep dive into the exact steps for vital signs. So, temperature, pulse, respirations, blood pressure, oxygen saturation, height, weight, and urinary output.
And we are pulling all of this straight from the NNAAP Skills Handbook.
Yeah, and then we're going to break down physical care practice questions, stuff like ADLs, hygiene, feeding, mobility.
Because the goal here isn't just rote memorization. We want to uncover the actual why behind all these strict rules.
Right, so you actually understand the clinical logic, which is how you're going to ace the exam and provide safe care. So let's just dive right into it.
Let's do it.
I want to start with measurement mechanics. The quantitative data, the numbers that tell us how the resident's body is functioning.
The raw data of human survival, basically.
Yeah. So let's look at skill 6 and 7, radial pulse and respirations.
Okay, so the clinical guidelines for this are super specific, and it starts before you even lay hands on the resident.
Right, you have to explain the procedure face to face. But, let's be real. If you're busy and have a dozen residents, stopping to have a whole face-to-face chat just to take a pulse feels, kind of inefficient.
Oh, I totally get why it feels that way. But physiologically speaking, anxiety completely alters vital signs.
Oh, because of the adrenaline.
Exactly. If you just walk in, loom over the bed, and grab their arm without warning, you trigger a sympathetic nervous system response. Cortisol spikes, their heart rate shoots up, and their breathing gets shallow.
So by skipping the explanation, you're actually corrupting the data you're trying to measure.
You are. So once you have their consent and they're calm, you find the pulse, you place your fingertips on the thumb side of their wrist.
Okay, wait, why the thumb side specifically? And why fingertips instead of your own thumb? I feel like I see people check their own pulse with their thumb all the time.
Well, your thumb actually has its own pulse, the princeps pollicis artery.
Oh, wow. I didn't know it had a specific name.
Yeah. So if you use your thumb, especially if you press down hard, you're going to feel your own heart rate echoing back at you.
That makes total sense. The thumb side of their wrist.
That's just anatomy. The radius bone runs down the thumb side. So when you press the radial artery against that hard bone, it magnifies the pulsation.
Got it. Okay, so here's the rule that I know frustrates people. You have to count the beats for 1 full minute.
1 full minute, non-negotiable.
I know people are tempted to count for 15 seconds and multiply by 4, though. Why is that such a bad idea?
Because human physiology isn't a perfect metronome.
It's like watching a 15-second trailer and assuming you know the whole movie, right?
That is a perfect analogy. You miss all the irregular rhythms. If a resident has atrial fibrillation, their heart might beat normally for 10 seconds, drop a beat, and then flutter rapidly.
So if you only check those first 15 seconds, you document a totally normal heart rate.
And you would have literally just fabricated clinical data. The evaluator gives you a scoring margin of plus or minus 4 beats for the pulse.
That is a really tight window.
It is, because accuracy is life or death. If their heart rate is 58, but you miscount and say it's 62, a nurse might give a cardiac medication that they really shouldn't have.
Yikes. Okay, so what about respirations? The margin there is plus or minus 2 breaths, right?
Right. And you also have to count for a full minute, but the tricky part is the Hawthorne effect.
Oh, right, where observing something changes the behavior.
Exactly. If you tell someone, I'm going to count your breathing now, their conscious brain takes over. They'll start breathing weirdly.
You basically have to be stealthy about it.
You do. You keep your finger on their wrist, like you're still checking their pulse, but you subtly watch their chest rise and fall.
Okay, moving on to skill 14, weight, and skill 13, urinary output. Let's start with the scale.
You have to ensure they have non-skid footwear on before they even walk to the scale.
Not just regular socks.
No, regular socks on a slick floor are a massive fall hazard. But the other big thing is you have to zero the scale before they step onto it.
Forgetting to zero the scale before the patient steps on. Yeah, this is a classic Cert Prep Academy question that trips people up all the time.
It really does. People are so used to digital scales at home that just auto-zero.
Right, you just tap it.
But mechanical scales in a facility get bumped all the time. If the sliding weights are off by 2 pounds and you don't fix it, you get a bad reading. And the margin of error is plus or minus 2 pounds.
Or 0.9 kilograms. And why is 2 pounds such a big deal?
Fluid retention. If a congestive heart failure patient gains 2 pounds overnight, it's not from eating too much. It means their body is retaining roughly a whole liter of fluid.
Oh, wow. So if your scale was wrong, the doctor might prescribe heavy diuretics that they don't actually need.
Exactly. Now, for urinary output, it's all about how you read the measurement. You put the container on a flat surface and read it at eye level.
Like in the meniscus, right?
Yes, the fluid curves up the sides of the plastic. If you look down from above, the angle distorts the line.
So you have to squat down, get at eye level, and round up to the nearest 25 milliliters.
Yep, plus or minus 25 milliliters is your margin of error there.
Okay, let's transition to the most complex measurement skill in the exam, blood pressure.
This is where we really separate the electronic cuff, which is skill 12, from the manual cuff, which is skill 23.
We really need to focus on the manual one. So you start by wiping the bell or diaphragm and the earpieces with alcohol.
Right, for infection control. Then you position the resident's arm palm up. You have to physically feel the brachial artery at the inner bend of the elbow with your fingertips.
And you place the arrow on the cuff directly over that artery.
Because if it's not lined up, the bladder inside the cuff won't compress the artery evenly.
Okay, so then you have to inflate it.
Yeah.
And the exam standard says to inflate between 160 and 180 millimeters of mercury.
Right. You are trying to apply enough pressure to temporarily collapse the artery and stop the blood flow.
But wait, the handbook says if you hear a beat immediately upon deflation, you have to completely deflate it and reinflate to no more than 200 millimeters of mercury. What does that actually mean?
That is called the auscultatory gap, or underinflation.
Okay, break that down for me.
If you hear a beat the literal second you start letting air out, it means you never pumped it high enough to cut off the blood flow in the first place.
Oh, because their systolic pressure was higher than 180.
Exactly. So if you just write down 180 as their top number, you're artificially lowering their blood pressure on paper. You have to completely deflate it to let the trapped venous blood escape.
You can't just pump it up higher right away.
No, because the trapped blood alters the sounds. You drop it to 0, let the arm rest, and then pump it to 200.
And as you let the air out, that first sound you hear is the systolic. And the very last sound before it goes completely silent is the diastolic.
Right. And you always round UP to the nearest even number. The margin of error is plus or minus 8 millimeters of mercury.
So you're never writing down an odd number for manual blood pressure.
Never.
Okay, so vitals give us the numbers, but a CNA's primary hands-on work involves activities of daily living, ADLs. Let's dive into the practice questions for hygiene.
Perineal care is a huge focus here.
The golden rule is always wash from front to back, genitalia toward the anus.
And you have to understand why the wrong answers on the exam, like using circular motions or wiping back to front, are so deadly.
It's all about E. coli, isn't it?
Yes, E. coli is perfectly normal in the colon, but if you wipe back to front, you introduce that anal bacteria into the urinary tract.
Which causes a UTI. And in the elderly, a UTI isn't just uncomfortable, it causes acute delirium.
Right. They can become completely confused, hallucinate, and become a massive fall risk. Front to back is a surgical maneuver to prevent sepsis.
That leads right into bed baths. You wash the face first with clean water, no soap, and then move down the body. Arms, chest, abdomen, legs, and perineal area last.
Always from cleanest to dirtiest.
And you only expose the specific area you're washing.
Because of thermoregulation. If you expose their whole body, the water evaporates and they can become hypothermic in minutes.
What if a resident on bed rest gets redness over their sacrum? I'd instinctively want to rub some lotion on it or maybe a heating pad.
No. That is exactly what you should never do.
Wait, really? Why?
Because the redness means the tissue is suffering from ischemia, lack of oxygen from the pressure. If you rub lotion on it, you make the skin macerated and weak.
Oh, like when your fingers get wrinkly in the tub.
Exactly. And if you use a heating pad, you increase the metabolic demand for oxygen in an area that already has no blood flow. You speed up the tissue death.
Wow. So the only correct first response is increasing their turning frequency and reporting it to the nurse.
Yes. And if they already have a stage 2 ulcer and open blister, you never use soap. You follow the nurse's exact wound care orders.
Let's talk about oral and nail care. If a resident is unconscious, you use a swab or sponge with suction, right? Never a toothbrush.
Correct, because they have no gag reflex. If you use a toothbrush and water, they will aspirate.
And what about the diabetic exception for nail care?
CNAs never cut the toenails of a diabetic resident. You only file them straight across.
Because of the neuropathy and poor circulation.
Yes. If you accidentally nick their skin, they won't feel it, and the lack of blood flow means it won't heal. It can lead to amputation.
Cert Prep Academy actually has a great breakdown of why diabetic foot care is so restricted for CNAs in their free study guides.
They do. It's a very clear explanation.
Okay, moving on from hygiene to nutrition and safety. Feeding and toileting.
Feeding safety is all about preventing aspiration. Residents must be sitting at a strict 90-degree angle.
And if they have one-sided weakness, like from a stroke,
You position the food tray on their unaffected, strong side, so they can see it and reach it safely.
what about altered diets, like pureed foods?
For pureed diets, you use a spoon with small amounts. You never use a straw.
Because a straw shoots the liquid straight to the back of the throat.
Right, it bypasses the oral phase, and if they have swallowing difficulties, it goes straight into their lungs. Thickened liquids have to be served exactly as ordered.
And if they start choking or have difficulty swallowing,
You stop immediately and report it. You never lay them down, and you don't try to force water down their throat.
right. And for maintaining independence, the practice questions emphasize cutting food into bite-sized pieces rather than just feeding them yourself, right?
Exactly. Maintaining their dignity is paramount.
Okay. Toileting and incontinence. For bedpans, the resident needs to be in semi-Fowler's position.
Which is an angle of 30 to 45 degrees, or sitting completely upright.
And after incontinence, soiled linens go straight into a designated hamper inside the room. You never rinse them in the sink.
Never. Because the water pressure hitting the feces aerosolizes the bacteria all over the bathroom.
So if I help a resident to the toilet, can I just step out and tell them to ring the call bell when they're done, just for privacy?
Absolutely not.
Yeah.
Sitting on the toilet can stimulate the vagus nerve when they bear down, which drops their heart rate and blood pressure.
Oh, vasovagal syncope.
Right. So if you leave them alone, they could pass out and hit their head. You have to stay nearby for safety, assist with hygiene, and help them stand.
Safety overrides privacy there. Let's move into our final physical care section, independence and mobility. Transfers, dressing, and range of motion.
The rules for dressing someone with weakness are very strict.
Yeah, the unbreakable rule is you dress the affected or weaker side first. And when undressing, you remove from the unaffected or stronger side first.
Think about the mechanics. If you put a shirt on their strong arm first, the fabric is anchored. Trying to force a paralyzed arm into the other sleeve can dislocate the shoulder.
So we need a memory aid here. Think, weak goes in first, strong comes out first. Or maybe dress the weakness, undress the strength.
I love that. Dress the weakness, undress the strength. It totally protects the vulnerable joint.
Okay, what about transfers?
The first step is always lock the wheelchair brakes.
And when you're using a gait belt, you stand on the resident's weaker side, slightly behind them.
Right, because if they are going to fall, they will likely collapse toward their weak side. You keep your feet shoulder width apart and bend at the knees to catch them.
You know, you'll see gait belt positioning questions phrased 5 different ways on the Cert Prep Academy practice tests, so you have to know this cold.
It's heavily tested, just like the rule for hip replacements.
Oh, right. Question 1 in the practice set. Never let the hip angle drop below 90 degrees.
You have to use a raised toilet seat. If they sit on a low toilet or lean forward or cross their legs, the leverage can pop the artificial joint right out of the socket.
It's pure structural engineering. Okay, we've covered the skills. Let's talk exam strategy and deciphering the score report.
The NNAAP written exam is 70 questions, but 10 of those are unscored pre-tests.
And then the skills test requires you to perform 5 random skills.
Exactly. And if you happen to fail the skills test, you get a score report.
Which people usually dread looking at.
But you shouldn't, because the report tells you exactly which step you missed. You have to get satisfactory on all 5 skills. If you get unsatisfactory, it's usually because you missed a critical element step.
Like forgetting to zero the scale or failing to lock the wheelchair brakes.
Right. The report gives you the exact step number.
So don't look at a failing score as a defeat. Use it as a roadmap. If you know exactly which step you missed, you can go back to the Cert Prep Academy flashcards and lock that specific critical step into your brain for next time.
It totally takes the mystery out of it.
All right, let's do a rapid-fire 1-minute recap of our main takeaways.
Measurement margins are strict. Plus or minus 4 beats for pulse, plus or minus 2 breaths, plus or minus 8 millimeters of mercury for blood pressure.
Hygiene is all about front to back to prevent UTIs.
Dress the weak side first to protect the joints.
Keep them at 90 degrees for feeding to prevent aspiration.
And always prioritize safety and reporting over independent interventions, especially for skin issues or choking.
Awesome. And if you're studying for this right now, listen up. CertPrepAcademy.com is completely free. No sign-up required to get started. There's a 70-question practice test that mirrors the real NNAAP exam, free study guides covering every topic on the test, and flashcards to help lock in the key terms. Everything you need to pass is in one place, and it costs nothing. Head over to CertPrepAcademy.com right now. Link is in the description.
It is an amazing resource. Definitely use it.
Absolutely. Well, that wraps up Episode 4. Be sure to queue up Episode 5, where we'll keep moving through the core material. Until then, keep studying hard. You've got this.
See you next time.